Hello, this is an AGACNP Board certification review on infections and antibiotics using information I learned from some review courses that I took, like Barkley and Associates AGACNP Live Review course and ANAs. Let's get started with bacterial classifications and the specific bacteria to focus on for the boards. The gram-positive bacteria are the ones that have the thick cell wall, and that's why they retain their purple color after gram staining. These would be Staphylococcus, Streptococci, Enterococci, Bacilli, and Corynebacterium. Then we have the gram-negative with the thin cell walls, and they do not retain the purple color after staining. These include, which I'm not able to pronounce all of these, so it's the Serratia marcescens, and we have E. coli, Klebsiella, Pseudomonas, Proteus, Mirabilis, then the Moraxella, Caterpillar, and then Enterobacter. The gram-positive bacteria, specifically Staphylococcus aureus, is important to know about. It includes MRSA and is commonly associated with skin infections, pneumonia, and sepsis. Second important one to know is Streptococci pneumoniae, and it is actually not typically considered part of the normal flora of the respiratory tract. However, it can be a transient colonizer in the upper respiratory tract in some individuals. This does not always lead to the illness, but it can become pathogenic under certain conditions, such as when the person's immune system is weakened, or if the bacteria manages to invade normally sterile parts of the respiratory system like the lungs, leading to pneumonia, or it may become pathogenic in the presence of other risk factors like smoking, chronic lung disease, or following a respiratory infection like influenza. This is an important distinction to understand in the context of AGACNP boards, as it relates to both the prevention and treatment of pneumococcal infections. Streptococcus pneumoniae is a major public health problem, as it is a main cause of otitis media, sinusitis, bronchitis, community-acquired pneumonia, bacteremia, sepsis, and meningitis. Next, let's review Group A Streptococcus, which causes strep throat, skin infections, and the rheumatic fever. Enterococcus species includes the E. faecalis and E. faecium, often associated with urinary tract infections and bacteremia, especially in healthcare settings. So everybody's familiar with C. diff, that causing antibiotic-associated diarrhea and colitis. And then we have the Corynebacterium. Corynebacterium diphtheria causes diphtheria, a potentially life-threatening upper respiratory tract illness. The pathogenesis and toxin production is the important part to know. So understand how diphtheria toxin produced by C. diphtheria disrupts protein synthesis in cells, leading to cell death and tissue injury. The toxin is responsible for the serious systemic effects of diphtheria. The clinical presentation is going to have classic symptoms including the presence of a pseudomembrane in the throat that's gray. There's going to be a sore throat, fever, and swollen lymph nodes. Diphtheria antitoxin is administered to neutralize the effects of the diphtheria toxin already circulating in the blood. And the antitoxin is not a routine stock in many hospitals due to the rarity of the disease in countries with high vaccination rates. So it may need to be obtained from like the health department or public health authorities. Before administration, a skin test may be conducted to check for hypersensitivity to the antitoxin. But antibiotic-wise, which is the whole point of this, is that the antibiotics in diphtheria is to eradicate the C. diphtheria and the production of the toxin. So erythromycin or penicillin G is typically used, and antibiotic therapy usually continues for about 14 days or as directed by clinical judgment. So in addition to the antitoxin and antibiotics, supportive care is crucial. This could be isolation, monitoring, managing complications like airway obstruction, treatment of any cardiac or neurogenic complications that arise due to the toxin's effect. It's essential to ensure that close contacts of the patient are also identified and treated prophylactically with antibiotics, and that they are up to date with their diphtheria vaccinations or receive appropriate booster doses. The prevention is through vaccination, and it is the most effective strategy and is part of the routine childhood immunization schedules in many countries. Be aware of the importance of the immunization against diphtheria with your DTaP vaccine, which is your diphtheria, tetanus, and acellular pertussis. Carrier state is that some individuals can carry C. diphtheria in their respiratory tract without symptoms, which can be a source of transmission. It is important to understand how to manage infections in general. So our first step is going to be an assessment and recognition. We want to evaluate the patient for signs and symptoms of the infection, such as fever, chills, redness, swelling, pain, pus, or other indications. You want to obtain the patient's history, including any recent procedures, hospitalizations, device usage, travel, or antibiotic use. Also, you want to perform or order appropriate diagnostic tests. So we want to do a diagnosis, and to do that, we need to culture our blood, urine, sputum, wound, imaging studies, or rapid antigen tests that are needed to identify the causative organism and source of infection. We want to assess for systemic involvement to determine if the infection is localized or has progressed into sepsis. Empiric therapy is going to be started based on the suspected pathogens, local resistant patterns, and the severity of the infection. You want to choose the route of administration, oral or intravenous, based on the severity of the infection. You want to provide supportive care. You want to do monitoring, but source control, identifying and managing any source of the infection, like draining abscesses or removing infected devices or foreign bodies, or surgical interventions if necessary, is important. And then antibiotic stewardship, preventing the spread of that infection, educating your patient on and their family about the infection, about the transmission, the treatment, the prevention of future infections, and advising when to seek further medical attention if symptoms do not improve. And you always want to set up a follow-up with your patient because you want to ensure the resolution of the infection and to manage any complications that may have arisen. Empiric therapy refers to the initiation of antibiotics when an infection is suspected, but not yet confirmed by culture. You use the site of infection, community versus hospital-acquired, patient allergies, and your local resistant patterns. As an example here, I have listed some gram-positive bacteria infections like cellulitis, which is going to have either Staphylococcus aureus or group A streptococcus as the most likely bacteria. And if MRSA is what you are suspicious for, you want to use vancomycin, but for group A strep, you can use cefazolin, clindamycin, linezolid, or daptomycin. You could also get endocarditis from gram-positive bacteria. Acute endocarditis usually has Staphylococcus aureus, and subacute is viridans, streptococci, or enterococci. And for the acute version of our endocarditis that has the Staphylococcus aureus, we want to, again, use vancomycin and ceftriaxone together. And for subacute, you want penicillin plus gentamicin. The most common gram-negative bacteria you will see are listed in the next couple slides, starting with E. coli, which is a common urinary tract infection bacteria, and it is also known for gastroenteritis. We also have Pseudomonas, which is associated with hospital-acquired infections, including pneumonia and bloodstream infections. Klebsiella, We also can say that that causes pneumonia and bloodstream infections and wound infections. Then we have Acinetobacter, which is known for its resistance to antibiotics and its role in various healthcare-associated infections. We also have Neisseria meningitis, which is a cause of meningitis and septicemia. We also have Neisseria gonorrhea, which is a causative agent of sexually transmitted infection, gonorrhea. H. pylori, which is associated with peptic ulcers and gastric cancer. Then there's Proteus mirabilis, which is commonly found in the human intestinal tract, and it's known for its ability to cause urinary tract infections, particularly in patients with complicated UTIs or with long-term urinary tract catheters. And it produces urease, which can lead to the formation of kidney stones. It's noted for its characteristic of swarming motility on solid media. Then we have Moraxella catarrhalis. This causes infections primarily in the respiratory system because it can be a part of the normal flora of the upper respiratory tract. It could cause otitis media in children and exacerbations of chronic obstructive pulmonary disease. And it causes exacerbations of chronic obstructive pulmonary disease in adults. Often produces beta-lactamase, which confers its resistance to penicillins. Then we have Acinetobacter, which is particularly known to cause a range of hospital-acquired infections, including pneumonia, bloodstream infections, and wound infections. It can be a multi-resistant form, and it makes infections difficult to treat. The Enterobacter, they are commonly found in the environment and in the gastrointestinal tract of humans and animals, capable of causing various nosocomial infections, including UTIs, respiratory tract infections, bacteremia, and some of the species like Enterobacter chloeae can develop resistance to drugs during treatment, notably producing extended spectrum beta-lactamase. More bacteria, including acute otitis media, sinusitis, bronchitis, meningitis, and CAP, are caused by S. pneumoniae, Moraxella catarrhalis, and H. influenza. These infections have the empiric therapy of amoxicillin, and you can use the broad spectrum version of amoxicillin, clavulanate, or Bactrim, or cefuroxime. Peritonitis with ruptured viscus would be an infection caused by gram-negative bacteria, and empiric therapy includes metronidazole plus a third-generation cephalosporin or Zosyn. Always consult local antimicrobial susceptibility patterns when selecting an antibiotic regimen. I did provide some examples while going through the different bacteria, but now let's focus on the infections and the actual empiric antibiotic choices that we're going to probably see most likely on the exam. First, acute otitis media, sinusitis, and bronchitis are both from a couple of slides ago, which is your amoxicillin, your amoxicillin clavulanate, your TMP, SMX, or your cefuroxime. Then we have the endocarditis, which is your Staph aureus for the acute endocarditis, and we would treat that with a vancomycin plus a ceftriaxone. Then we have the subacute endocarditis, which has the bacteria viridans and streptococci and enterococci as possibilities. That's why we would use penicillin plus gentamicin. For cellulitis, group A strep or Staph aureus, which are the most common bacteria of cellulitis, would be covered by cefazolin. If there is a MRSA Vancomycin, clindamycin, linezolid, teptomycin are all also options. And for community-acquired MRSA, I see a lot of documentation for Bactrim plus cephalexin. If there is a Bactrim allergy, use of clindamycin is appropriate for that patient. And then if there is a sepsis in the patient that you want to treat, then we want to use vancomycin for sure, plus one of the ceftriaxone, rocephin, cefotaxime, or cefepime, or you can use Zosyn, imipenem, or meropenem. Next, we have our intra-abdominal infections, which usually have the bacteria E. coli, Klebsiella, Bacteroides, Fragilis, and Enterococci. So we want to use a metronidazole plus a cefuroxime, ceftriaxone, cefotaxime, ciprofloxacin, or levofloxacin. For peritonitis with a ruptured viscus, you're going to see bacteria such as coliforms and Bacteriocides fragilis, and metronidazole plus a cephalosporin or Zosyn is appropriate for this type of infection. For diverticulitis, we want to use a metronidazole plus a ciprofloxacin, ceftazidime, clindamycin, ampicillin, and Fortaz. If osteomyelitis is suspected due to trauma, nafcillin plus a ciprofloxacin is appropriate. And meningitis, I did put this table here from an article which aligns with the actual review course material. And I wanted to let you guys know that the most common one that I saw that was emphasized was the first one here, the Streptococcus pneumoniae, and that is treated with vancomycin plus a third generation cephalosporin, and you want to use as an alternative a meropenem or a fluoroquinolone. It is unavoidable to get a UTI question on the boards. Here it is. If there is cystitis, you want to give macrobid times 5 days, or Bactrim times 3 days, or fosfomycin times 1 dose. That's my favorite, by the way. And then if there's pyelonephritis, the first, ciprofloxacin or levofloxacin or ceftriaxone. If there is UTI in pregnancy, you want to go ahead and start with amoxicillin. Or if that's not available or there's an allergy, you could do macrobid. And either one of these for 10 days is what's recommended. Also noted were preoperative prophylaxis. Prophylactic antibiotics should be administered within 60 minutes before the incision for colorectal surgeries. Vancomycin is given when there is actually a known MRSA risk or the patient has had a documented beta-lactam allergy. The choice of antibiotics should cover both aerobic and anaerobic bacteria commonly found in the colon. A combination of antibiotics such as a cephalosporin with metronidazole or a single agent with broad spectrum cover like ertapenem is typically used. Vancomycin, if used, again, should be started within 120 minutes before the surgical incision due to its longer needed infusion rate or time. And non-perforated appendectomies should get prophylactic antibiotic, and especially if there is any indication of inflammation of the appendix or if it's gangrenous on visual inspection during surgery. Antibiotics that cover common enteric pathogens, including gram-negative rods and anaerobes, used a single dose of a first or second generation cephalosporin is often sufficient. If the patient is at high risk for MRSA, again, if there is an allergy to any other agents, vancomycin can be considered. For both types of surgeries, if the surgical procedure is expected to be lengthy, redosing the antibiotic may be necessary to ensure that there's adequate lengthy serum and tissue concentrations throughout the operation. It's also crucial to avoid unnecessary prolonged use of prophylactic antibiotics beyond the surgery to minimize the risk of antibiotic resistance. It is important to adhere to your institution's guidelines and the latest recommendations for surgical and infectious disease societies. Always consider patient-specific factors too, like allergies, previous history of MRSA, and your local microbiome's resistant pattern. It is also important that we know vancomycin's complications. So there is red man syndrome, nephrotoxicity, ototoxicity, drug fever, phlebitis, thrombocytopenia, anaphylaxis, antibiotic-associated colitis, and of course, vancomycin-resistant enterococci, which is RVRE. There was emphasis on being aware of the red man syndrome. This is due to too rapid infusion of vancomycin. So make sure to understand it looks different on different skin type and skin tones. So that's why I have this picture here, because I want you to understand what it looks like on African American skin or those with pigmentation in their skin, because a lot of the pictures that we see in our medical education do not include those people of color. So make sure that we are aware that it does look different with patients that have pigmentation in their skin. Vancomycin is a glycopeptide antibiotic used to treat a number of gram-positive bacterial infections, including those caused by methicillin-resistant Staphylococcus aureus, and it works by inhibiting the cell wall synthesis. With the red man syndrome, this is an infusion-related reaction to the vancomycin. It is not an allergic reaction, but a histamine release caused by rapid infusion of the drug. The name red man syndrome comes from the characteristics of red flushing of the skin, particularly on the face, neck, and upper torso. Symptoms can also include itching, erythematous rash, and in severe cases, hypotension and angioedema. To prevent and the management of this includes the incidence of red man syndrome can be reduced by slowing down the rate of the vancomycin infusion. Typically, infusing it over 1 to 2 hours can help prevent this reaction. Pre-medication with antihistamines like diphenhydramine can also be used to mitigate symptoms. If the red man syndrome occurs, stopping the infusion can help alleviate symptoms. Once the symptoms have resolved, vancomycin may be restarted at a lower, slower rate, often with antihistamine support. And then dosage and monitoring. Vancomycin dosing should be based on body weight and renal function. Therapeutic drug monitoring is often necessary to ensure therapeutic levels are achieved without reaching toxic concentrations, especially since vancomycin has a small therapeutic window. The goal, though, will be to have a trough level that will depend on the type and severity of the infection being treated. For each one of these, we should know at least 2 antibiotics to treat them with. So I went over the antibiotics listed and I pulled the list of antibiotics that cover all of these. So for our enterococci, MRSA, MSSA, pneumococci, and streptococci, which are all gram-positive. You can use ceftaroline, daptomycin, linezolid, tedazolid, Bactrim, or vancomycin. For the gram-negative rods, Enterobacter, E. coli, Klebsiella, Proteus mirabilis, and Pseudomonas. Antibiotics cefepime, ceftalozone, tazobactam, imipenem, meropenem, doropenem, zosyn, and quinolones all cover these. We can't study without having practice questions. Let's do some questions with the information that was just reviewed. So the first question says, select all antibiotics that can be used as first line for the treatment of uncomplicated cystitis in a non-pregnant adult. So what do you guys think? Pause if you need a minute. So A, nitrofurantoin. B, TMP, SMX. C, phosphomycin are your answers, right? All 3 of those. All right, next. Select all appropriate initial empiric antibiotic therapies for a patient with suspected acute pyelonephritis who is hemodynamically stable but has nausea and cannot tolerate oral medications. So we have A, IV ceftriaxone, B, oral phosphomycin, C, IV gentamicin, D, oral TMP SMX, or E, IV fluoroquinolones.
which ones do you believe are the correct answers? If you said A, C, and E, you are correct. The answers are A, C, and E. IV ceftriaxone, IV gentamicin, and IV fluoroquinolones. A 35-year-old female presents to the ED with high fever, chills, and flank pain. A urine analysis indicates the presence of leukocyte esterase, nitrates, and white blood cells. The patient has no known history of allergies and no significant past medical history. Which of the following is the most appropriate initial empiric antibiotic therapy for this patient suspected of having acute pyelonephritis? What do you guys think? If you said B, IV ceftriaxone, you are absolutely correct. So the empiric antibiotic choices for urinary tract infections, specifically pyelonephritis, is always fluoroquinolones or TMP SMX with initial parenteral therapy like ceftriaxone in severe cases. A 68-year-old male with a history of chronic obstructive pulmonary disease presents with 3-day history of cough, fever, and shortness of breath. The chest x-ray confirms the diagnoses of community-acquired pneumonia. He has not received antibiotics in the past 6 months. Which of the following is the most appropriate initial empiric therapy? We have A, azithromycin monotherapy, amoxicillin clavulenate, C, ceftriaxone plus azithromycin, and then D, doxycycline monotherapy. So again, this is the patient that has COPD. So if you chose C, ceftriaxone plus azithromycin, you are correct. So remember, in patients with CAP who have comorbidities, conditions like COPD, or those that have had recent antibiotic use, a combination of therapies is often recommended, such as azithromycin or doxycycline, which is the typical ones. For patients with comorbidities, adding that beta-lactam, such as ceftriaxone, to the regimen provides that broader coverage and is in line with the current guidelines for CAP management. So it's really important that we know this for our board exam. A 72-year-old male who has been on a mechanical ventilator for the past 5 days following a cerebral vascular accident develops a new fever, purulent sputum, and shows new infiltrates on a chest x-ray. Which of the following is the most appropriate initial empiric antibiotic therapy for suspected ventilator-associated pneumonia in this patient? I have a feeling oral is not the answer, but A, oral levofloxacin, and then we have B, IV cefepime, C, IV vancomycin, and then D, oral azithromycin. If you chose B, IV cefepime, that is the correct answer. And in cases of HAP or VAP, especially when the onset is late or there's a high risk of multi-drug resistant pathogens like Pseudomonas, and anti-Pseudomonal antibiotics such as cefepime is recommended. The choice of intravenous route is appropriate for a patient with severe pneumonia and for those who are hospitalized on the mechanical ventilator. While vancomycin is crucial for MRSA coverage, it's not included in the initial empiric therapy unless there is a high suspicion of risk of MRSA. A 45-year-old presents to the clinic with a red, swollen, and tender area on the lower leg. There is no drainage or abscess formation. The patient has no significant medical history and no known drug allergies. Given the likelihood of streptococcal infection in the uncomplicated cellulitis, which of the following is the most appropriate initial empiric antibiotic therapy? You have A, oral cephalexin, B, oral TMP SMX, C, oral doxycycline, or D, oral clindamycin. If you chose A, oral cephalexin, you are correct. So for uncomplicated cellulitis typically caused by streptococci, the first line treatment option is that beta-lactam antibiotics such as cephalexin. Like TMP, SMX, and doxycycline are more appropriate when MRSA is suspected, especially in the cases of purulent cellulitis or in geographical regions with high prevalence of MRSA. Clindamycin can be considered, if the candidate's knowledge of selecting an appropriate antibiotic based on clinical presentation and likelihood of the causative organism. So it's important that we understand that. A 55-year-old man with diabetes presents to the emergency room with severe pain, erythema, and swelling of the left lower leg. He has fever of 102 degrees Fahrenheit, and the leg has areas of bullae and necrosis. Which of the following antibiotic regimen is the most appropriate for initial empiric therapy for suspected necrotizing fasciitis? So what do you guys think? A, oral amoxicillin? I don't think so. But B, IV vancomycin plus Zosyn, C, IV ciprofloxacin, or D, IV penicillin? So we have necrotizing fasciitis. What do you guys think the answer is? Okay, B, that's the correct answer. So B is the correct answer. So IV vancomycin plus Zosyn. Necrotizing fasciitis is a severe, rapidly progressing infection that requires immediate broad-spectrum antibiotic therapy. The chosen regimen should cover MRSA, which is your vancomycin, as well as the broad range of aerobic and anaerobic bacteria, which Zosyn covers. Oral antibiotics are not appropriate for the severity of the infection presented in the scenario, and the combination of vancomycin and Zosyn is standard empirical choice for necrotizing fasciitis, providing the necessary broad coverage. Okay, next one. A 40-year-old female presents with mild to moderate lower abdominal pain, fever, and leukocytosis. A CT scan reveals an inflamed appendix with no perforation or abscess. Which of the following antibiotic regimen is the most appropriate for initial empiric therapy for this patient's uncomplicated intra-abdominal infection? We have A, oral azithromycin, B, IV ciprofloxacin plus metronidazole. We have C, intravenous vancomycin, and D, intravenous amoxicillin. I feel like every intra-abdominal infection is going to have flagell. So B, if you pick B, I would pick, there we go, IV ciprofloxacin plus metronidazole. So for uncomplicated intra-abdominal infections like appendicitis without perforation or abscess often involve a mix of aerobic and anaerobic bacteria. So a combination of ciprofloxacin to cover the gram-negative aerobes and some gram-positive organisms, and then metronidazole to cover anaerobes is the appropriate combination for this scenario. Single agents like ticarcillin, clavulinate can also be used. A 60-year-old male with a history of diverticulitis presents to the emergency department with severe abdominal pain, fever, and leukocytosis. A CT scan reveals diverticular abscess and peritoneal inflammation. Which of the following is the most appropriate initial empiric antibiotic therapy for this patient's complicated intra-abdominal infection? We have oral Cipro as A, B, IV ampicillin, C, Zosyn, IV, and then D, azithromycin. If you picked Z, Zosyn, you are correct. So complicated intra-abdominal infections, such as those associated with diverticular abscesses, require broad-spectrum antibiotic coverage that targets a wide range of aerobic and anaerobic bacteria. Zosyn is an appropriate choice as it provides extensive coverage against both anaerobic and aerobic pathogens commonly involved in these infections. Now, carbapenems are another option for broad spectrum coverage, but they are not listed among the choices, but would be also suitable for this scenario. And then the other antibiotics listed, Cipro, ampicillin, and azithromycin, do not provide the comprehensive coverage for the likely pathogens in the complicated intra-abdominal infection. Okay, let's try this one. A 25-year-old college student is brought to the emergency department with a high fever, neck stiffness, and altered mental status. Lumbar puncture is planned. Which of the following is the most appropriate initial empiric antibiotic regimen for suspected bacterial meningitis in this patient? We have A, IV vancomycin plus ceftriaxone, B, IV aclavir, C, oral amoxicillin, and D, IV gentamicin. If you chose A, IV vancomycin and ceftriaxone, you are correct, because the empiric therapy for bacterial meningitis in adults typically includes a combination of vancomycin to cover the potential resistant Staphylococcus pneumoniae and the Listeria monocytogenes in certain age groups. And in the third generation cephalosporin, like ceftriaxone or ceftaxime, you can cover the Neisseria meningitis and S. pneumoniae. Aclavir would be used for suspected viral herpes meningitis maybe, and then amoxicillin and gentamicin are not standard empiric choices for bacterial meningitis in adults. We have a 48-year-old man with no significant medical history who presents with 4 days of increasing pain, redness, and swelling over his tibia, which he injured while playing soccer. He has no recent hospitalizations or antibiotic use, and there is no evidence of an open wound or ulcer. Which of the following is the most appropriate initial empiric antibiotic therapy for this patient's suspected acute osteomyelitis? A, oral Bactrim, B, IV cefazolin, C, IV vancomycin, or D, oral ciprofloxacin. If you chose B, IV cefazolin, you are absolutely correct because acute osteomyelitis is frequently caused by a Staphylococcus aureus, and in patients without risk factors like MRSA or an open wound, anti-staphylococcal penicillins or cefalozolin are appropriate choices for this empiric therapy. If the patient had risk factors for MRSA, vancomycin would be indicated. Example, like there was a recent hospitalization, the patient was an IV drug user, or maybe there's a known colonization from a prior exposure. Now, TMP, SMX, and ciprofloxacin are not first-line treatments for suspected acute osteomyelitis without MRSA risk factors. A 72-year-old man with a history of diabetes and chronic kidney disease presents with fever, confusion, and photophobia. CFF analysis is pending. What is the most appropriate empiric antibiotic treatment? We have the chronic kidney disease with the fever, confusion, and photophobia. A, we have the option of IV Cipro. B is IV ampicillin plus cefepime. C is IV vancomycin plus ceftriaxone. And D is IV meropenem. If you chose C, that is the correct answer, which is the IV vancomycin plus ceftriaxone. We want that one because in an elderly patient, especially with comorbid conditions, the empiric coverage should include antibiotics effective against a broad range of bacteria, including that L monocytogenes. Vancomycin and ceftriaxone provide the broad coverage. Ampicillin may be added to cover listeria in patients over 50 years of age or in those with immune-compromising conditions. We have a 70-year-old female with rheumatoid arthritis who's being treated with corticosteroids. She presents with pain and swelling in her right knee. Aspiration yields purulent fluid and osteomyelitis is suspected. She had a MRSA skin infection 2 years ago. Which empiric antibiotic is most appropriate? We have A, amoxicillin, IV, B, IV ceftriaxone, C, IV vancomycin, and then D, oral ciprofloxacin. And guys, at this point, every time I see MRSA, I am going to just pick C. And yes, it is C, because given the patient's history of MRSA infection, vancomycin is appropriate for the empiric coverage until culture results are available. Her immunocompromised state and previously MRSA history increases the risk of resistant organisms. A 63-year-old woman presents with signs and symptoms of urinary tract infection. She reports dysuria and increased urinary frequency. She has a history of type 2 diabetes and is currently not taking any antibiotics. Urine analysis confirms bacteriuria, and with all this, which is the most appropriate empiric antibiotic? A, this is the macrobid, and then B is the ciprofloxacin, C is vancomycin, and then D is flagyl. If you picked A, macrobid, or nitrofurantoin, I can never say that word, that is the correct answer. A patient with a history of IV drug use presents with a fever, back pain, and MRI shows evidence of a vertebral osteomyelitis. Blood cultures are drawn, but results are not yet available. What is the most appropriate empiric antibiotic therapy? A, TMP, SMX, B, IV cefalozolin, C, IV vancomycin plus cefepime, or D, IV ampicillin. What do you guys think? If you chose C, intravenous vancomycin plus cefepime, you are correct. Given the patient's history of IV drug use, there is a high risk for MRSA and
Other resistant organisms, broad spectrum coverage, including MRSA, is vancomycin, and gram-negative rods. Cefepime is warranted in this patient. Next, we have a 72-year-old male with COPD who is admitted to the hospital with a productive cough, fever, and new infiltrates on the chest x-ray. Sputum culture is pending. Which of the following regimens is the most appropriate for empiric treatment of this patient's community-acquired pneumonia? A, azithromycin alone. B, vancomycin plus ceftriaxone. C, zosyn. D, doxycycline or azithromycin plus ceftriaxone. If you picked D, you are correct. Doxycycline plus ceftriaxone is good because the patient has COPD and other comorbidities, and a combination of macrolide like azithromycin plus a doxycycline with a broad spectrum beta-lactam like ceftriaxone is recommended to cover typical and atypical pathogens. Now, a 45-year-old female with no significant past medical history presents with signs of cellulitis on her lower leg. There is no pus, abscess. She denies fever. She reports an allergy to penicillin. What is the most appropriate empiric antibiotic therapy? A is oral cephalexin. B is oral clindamycin. C is IV vancomycin. And D is oral ciprofloxacin. Which one did you guys pick? If you picked B, oral clindamycin, you are correct because she has a penicillin allergy, and clindamycin is what we talked about as the alternative for that.
Now we have a 32-year-old patient who presents with an acute, rapidly spreading area of erythema on the floor. There is no purulence or abscess formation, and the patient has no significant medical history or known drug allergies. The clinical presentation is highly suggestive of group A streptococcal cellulitis. Which of the following is the most appropriate initial empiric antibiotic therapy? What do you guys think? If you picked A, cefazolin, you are correct. So we know with the group A staphylococcus, it's usually sensitive to beta-lactam antibiotics, making cefazolin an appropriate choice for empiric therapy in a patient with non-purulent cellulitis. So like vancomycin, clindamycin, linezolid, and daptomycin are the alternatives that might be considered in the cases where MRSA is suspected if the patient had like a beta-lactam allergy, or in severe systemic infections, those could all be used. But since the scenario is pretty straightforward and the cellulitis is pretty much group A staphylococcus without any complications, cefazolin is preferred for its efficacy, safety profile, and its adherence to the antibiotic stewardship principles.
A previously healthy 40-year-old male presents with a 2-day history of fever, flank pain, and dysuria. He has no allergies, but is concerned about taking oral medications due to GI being upset. Which of the following would be the best choice for initial parenteral empiric treatment? If we have A, IM PCN, B, IV ceftriaxone, C, IV vancomycin, and D, IV metronidazole. If you chose B, IV ceftriaxone, you're absolutely correct. A 55-year-old man with a history of diabetes presents with swollen, red, and painful left foot. Radiographs and MRI suggest osteomyelitis. There is no history of MRSA infection or colonization. What is the most appropriate initial empiric antibiotic therapy? If you chose C, IV cefazolin, you are correct because remember, osteomyelitis is commonly caused by Staphylococcus aureus, and in the absence of MRSA risk factors, a first-line anti-Staphylococcus, penicillin, or cefazolin is appropriate. That's why we have cefazolin, and vancomycin would be more suitable, like if there was a history of MRSA infection or colonization, and doxycycline and gentamicin are not standard first-line agents for empiric treatments of osteomyelitis. So, IV cefazolin is the answer.
Match the following antibiotics to the urinary tract infection that are most appropriately used to treat empirically. Starting with A, pyelonephritis. Which one of these? Nitrofurantoin. We have TMP-SMX, we have phosphomycin, and then we have ciprofloxacin. So for pyelonephritis A, the empiric one would be 4, ciprofloxacin. Now let's look at complicated UTI in male patient B. For this one, it would also be ciprofloxacin, 4. And then for the C, uncomplicated cystitis, we would go ahead and use either nitrofurantoin, TMP-SMX, or phosphomycin, 1, 2, and 3. And that's it, guys. I hope this was helpful. Thank you so much for studying with me. I wish the best of luck for you out there, and I will see you on the next one.